I'm Heather. Welcome to the Bristol webinar today. So, a couple course disclosures. I obviously am affiliated with Bristol, so any of my presentations, the case studies are all Bristol based because that's what I have the biggest exposure to, and I truly believe that we go above and beyond on what we can show in the test. So I hope to share some of that with you and give that a little bit of a teaser today. But the stuff that I do find is a lot of my own information that I put together. So I do a lot of reading of research, and everything that I put in is research based. And honestly, some of the treatments have been from me spending all of the time in the thousands of tests that I have looked at and testing and retesting people to see what's working. So I think that's an important part. Just to kind of disclose, I do have a working relationship with Bristol. So today is going to explore clinical applications of salivary diagnostic testing and assessment, and then treatment planning for our patients with moderate to high risk bacterial profile. So that's most of what people are dealing with when they're using the salivary test for the most part. So I wanted to make sure that we went over interpretation, things that you can look at for that within the test. And then how do we think about leveling up our care to help take care of the dysbiosis that's taking place? So the course objectives today: identifying patterns of patients with moderate to high salivary risk scores, correlating the oral dysbiosis with gingivitis, perio, and systemic disease pathways, and evaluating what sort of treatment modalities we might want to put in for those high risk microbial environments, and then really putting together some targeted home care recommendations, because us clinicians are restart button, right? So what we put in the patient, for their home care is going to make a huge difference on their health pathway as well. They have to own up their disease and their home care, and we have to put the right tools in for them to be successful. And we will be going over a treatment case today as well. I try to always have some sort of treatment case involved. So what's so special about saliva? So saliva is pretty awesome. And without having enough saliva, we're going to be sick. We can't digest our food, and we won't have an even oral microbiome ever. So saliva health is super important. But saliva assessments could be pH. So we can look at the pH of the saliva. We can have biomarkers, and the oral microbiome is just one biomarker that we can look at for our patients. Physicians are using it for cortisol and other types of hormones to actually look at what's going on systemically. And then even with the salivary flow, we can also look at MMP8, which is an inflammatory marker, and that can tell us whether we have breakdown of the tissue that's active. So the lower the MMP8, the less the breakdown, the higher it is, then we're going to be in disease pathway, and our patients are going to have bone loss. So we will focus a lot more on the microbial makeup, because that's what Bristol does, is we look at the entirety of the oral microbiome. So we'll be diving into, the capability of looking at the oral microbiome and what that tells you about your patient. And the saliva is protective. So if we don't have enough saliva, we're going to be red and inflamed, and we're going to decay without having anything in there. So we really need to make sure that we are looking at saliva health and assessing our saliva flow for the health of our patients. So saliva is magic in the mouth, and it can give us clinicians so much information that we can assist our patients to health with that. So why should we be testing? So if you're not testing already, there's lots of reasons we could be testing. If your patient has bleeding and suppuration and bone loss issues, we need to know the reason why and what's causing that bone loss. Decay is another reason. I know strep mutans is the top bacteria everyone loves to talk about with decay issues, but we have 16 different bacteria in the score, and honestly, don't see strep mutans very often. So you really should know what you're addressing with your patients for decay so that you can actually treat what's going on. And maybe it's not bacteria at all, and you should start looking at saliva health and gut health, and sometimes the tests can give you some really great leads on that, and we'll kind of break that down a little bit. Occlusal wear. So Someone who's clenching and grinding probably has some airway issues and they might be deficient in nitric oxide, which could lead to blood pressure issues. So, Bristol's test will tell you whether the oral microbiome has the capability of reducing nitric oxide, which is an important part of vasodilation. So, if someone does have occlusal wear, there's probably some oral microbiome imbalances that could be impacting systemic health. So that's another really great reason. And then systemic conditions. So I work with functional medicine doctors on a daily basis. I'm actually paired with one now, and I do all of her oral health coaching for her clients. And there are over 3,500 studies that tie the oral systemic connection. So if you have health histories that are questionable, start thinking about testing because maybe they're not prone to periodontal disease because they don't have the autoimmune component that causes that bone loss. But maybe they have cardiovascular disease or their gut cognitive function, MS, GI issues, and it could be stemming from oral health. And the more you test, you'll realize people have dysbiosis way before bone loss and bleeding happens. So if we test preventatively, we could be subsided. So let's just talk about the good, the bad, and the ugly. So with disease pathways, there's a number of different things that can influence bone loss in our patients. So cortisol is one. So when we talk about sleep with that occlusal wear, and patients aren't getting a good amount of sleep or they are under a lot of stress, we might have high cortisol. That could impact the biofilm dysbiosis in a number of different fashions and influence inflammation. We know viruses can also cause some dysbiosis, and there's some relationships there as well. But it's bidirectional. Notice that on the disease side, the arrows are going both ways. So we can have oral dysbiosis and disease, and it's influenced by chronic inflammatory diseases and periodontal disease when those bacteria are swallowed also impact these as well. So it's bidirectional. If we think about autoimmune component of periodontal disease, it's all about tumor necrosis factor alpha and interleukins swimming around. So we can either have pathology exciting that, or we could have systemic disease pathways that are filtering in those interleukins and then feeding the inflammation in the body and in the mouth as well. And then food makes a huge difference for our patients as well when it comes to disease pathways, both on caries, but the bacteria that causes periodontal disease oftentimes also eat those carbohydrates and feed inflammation as well. So we really need to make sure that we're addressing diet for our patients who are highly inflammatory in nature. On the healthy side, a homeostatic oral microbiome is the goal for our patients. That means we have a good balance of beneficial bacteria, nitrate reducing bacteria, and we have, we're going to have bacteria that are problematic or pathogens in there in the mouth. You're never going to completely get rid of everything. It's about creating a homeostatic or a balanced state in the oral environment that creates homeostasis. We don't have breakdown of oral tissues and systemic health issues. And of course, diet plays a huge role in there. So we should be talking to our patients about nutrient-dense food, making sure that we're lowering sugar and thinking about sugar not just on a candy and soda level, but simple carbohydrates like crackers. I just had a conversation today about someone, just because you eat Annie's organic goldfish doesn't mean you're going to be feeding the bacteria any different. They don't care if it's organic or not. So we have to have those conversations. And these are all of the different factors we have to look at. And so often we just sort of look at, scaling and replaning and think that that's going to be our treatment always for our patients. Let's just talk about microbial translocation too when we're talking about the oral systemic connection. So there's two different pathways of how the microbes in our mouth get translocated into the body. So through swallowing and getting into the gut system, we can swallow, and a lot of the pathogens, even beyond just the typical red complex and orange complex, can have some impact on the gut barrier. And if we have a leaky gut problem, we're going to have immune system activation and raised interleukins and immune system responses that go downstream. So, and then I just want to point out too, low gastric juices. So many of our patients are on proton pump inhibitors. So they're not supposed to be long term. And if we have proton pump inhibitors, or I had my gallbladder removed a long time ago, I don't have enough acid in my stomach because I don't make bile. So if we don't have enough acid in our stomach to kill off the bacteria that aren't supposed to be there, we end up in gut dysbiosis, which leads to vitamin deficiencies and inflammatory cytokines. So that's one way we can have translocation, and it can impact our oral systemic side. And then through bleeding points. So if we do have really big inflammation and we're flossing and brushing and we've got bleeding points, it gets into the bloodstream and it can make its way to other places too. And we know that a number of the pathogens that we look for in the oral environment are connected to neurological disorder, heart disease, endocrine disorders, a gastrointestinal disease, cancer, and autoimmune diseases. Also, non-fatty liver, a non-alcoholic fatty liver can be highly tied to translocation as well. So, and then thus feeding inflammation in the body, and then that's going to come back to the mouth. So we have to look at the whole body and how our mouths are actually impacting our health, even beyond just bleeding points in the mouth. So it's important to understand that disease is bi-directional. So how we eat and what we have going on in our health history impacts periodontal disease, and periodontal disease will impact systemic health. So it's really important that we are really understanding what sort of microbial dysbiosis we have, and really start thinking about prevention through testing much earlier. I kind of challenge, preventative dentistry is, treating inflammation and bone loss when it's already happened. We could test before maybe and prevent the whole process from starting if this becomes a standard of care. So test, don't guess. So the salivary test can give you really helpful insights to determine treatment pathways and help you with your treatment, facilitation. So success is trying to get your patient from over, excited microbes in the mouth and getting them to that homeostasis phase where we can then quiet down the entire body. So there are over 800 different bacteria, fungi, and viruses in the oral environment, and they play a key role in oral and systemic health. So we should be gold at trying to disrupt that biofilm and make sure that we're helping our patients get healthy. So this is a little teaser of my protocol that we will be featuring on my website. So saliva protocol, it's sampling, analyzing, leveling up your care, implementing, verifying through retesting, and then assisting your patient with utilizing effective referrals for collaboration. So this course and a lot of my courses, and honestly, I've been teaching this basically to everybody who has been, part of the training. You sample, I help you analyze, and then we talk about how to level up and implement care. And then I think it's really important that we verify. And I don't think we can ever get our patients healthy at times if we're not assisting them through collaborative care with, making sure that we're getting them to the right medical facility, getting airway and nutrition under control with specialists for our patients to be really successful at getting healthy. So we're going to break this down just a little bit let's just talk about sampling for a moment. So there's a couple different ways that you can sample. I started with phase contrast microscopy. I had the pleasure at IOMT booth at Under One Roof with Amanda and Kristen King to talk about phase contrast microscopy. So phase contrast microscopy, you take a plaque sample and you put it under microscope and you get to look at the live bacteria in the mouth. It's super awesome. You don't really know what you're looking at. There's mobile and non-mobile bacteria, but it's a really great overview of, is there dysbiosis and should I test to know exactly what I'm looking at? So I love this real time. It's fantastic because I could sample a patient and then I could do treatment and then I could sample the patient at the end of my treatment and see if I subsided the pathology that I was seeing in the first, and I can put them side by side and show the patient, look, this is where we started and this is where we are at the end of your treatment. So success. If I still had pathology, then I could go back in and add some more things to make sure that I captured enough of the pathology to reduce the risk of them going back into cycle of disease. So it's fantastic. Salivary diagnostics is taking a salivary sample and sending it to the lab. So, and there's a number of different ones on the market. We'll talk a little bit about the different techniques of salivary testing, but this is the diagnostic tool. It's actually knowing exactly what you would have been looking at on the slide. So these are important because we need to know what's there so we know what we need to treat. And we know, how they can impact both oral and systemic disease. And on a really simple level, if you're not testing yet, start doing some pH samples with your patient, or maybe you're going to pair it with pH and nitric oxide strip testing. So you can take a really simple sample of the saliva and do a stick test and check the pH. pH is really important. The more pH balanced or alkaline the mouth, the more favorable it is for good bacteria. The nitric oxide score, it will be higher pH if you have high nitric oxide in the mouth. So assessing those types of things, nitric oxide is part of vasodilation. It's part of the immune system. It's part of your process of the white blood cells actually, eating the bad bacteria. But really important, low nitric oxide leads to high blood pressure in your patients. So these are two really simple things. Even if you haven't gotten your doctors on board with maybe doing salivary diagnostics, you can check in. If the pH is below 6.5 or 6.25, they're headed towards disease. So you want to make sure that you're doing something for that patient to increase the pH of their saliva, or they're going to probably end up with decay issues or even periodontal diseases tied to pH lower than 6.25 as well. Nitric oxide, we test for the gas nitric oxide with a strip test. And the lower it is, you want to bump that up. Like I said, high blood pressure is tied to low nitric oxide. So super important for vasodilation. We want good vasodilation in the mouth because if we don't have good vascular health, we're not going to fight off that infection. So that's a really important component for you to check in. So those are really two easy things that you can add if you're not doing the phase contrast microscopy or even salivary testing for diagnostic purposes. So bristle is a shotgun metagenomics test. It's different than a lot of the other types of tests on the market. So I just want to kind of touch a little bit about what types of testing there are in salivary diagnostics. So qPCR is what most individuals start with. I started with oral DNA before shifting to bristle in my office, but it's looking at a small target of bacteria. So most of those tests are looking at anywhere from 10 to 15 species, usually the red and orange complex, and some are now including things like viruses or just a few of the pathogens that might be involved in decay issues. And they give you a quantitative measurement. So they'll give you like a 10 to the 15th power, something like that. So it's quantitative, but it's very targeted. You're only looking at pathology. Okay. Shotgun metagenomics is a more advanced DNA sequencing process. It takes longer than qPCR because it's so extensive, but it's broad spectrum. So it detects all the bacteria, fungi, and viruses that could be present in that oral microbiome. So oftentimes the test will have anywhere between very low with bad diversity, 26 bacteria, to 150 bacteria. And you don't have to know everything about all of them. They do a really nice job at breaking down categories for you, so it takes the thinking out of it. But it's a lot more quantitative, and it's looking at relative abundance rather than quantitative measurements. And it's looking at beneficial bacteria, nitrate reducing bacteria in the bristle test. And it's looking at kind of some functional insights in the oral environment. So that's kind of the difference between the two tests that are the types that are on the market. I obviously love bristle because we're looking at everything. And honestly, with working with functional medicine doctors, it's way beyond just the red complex bacteria. So much of the time, I get this question: why do I need a test? How is it going to change my treatment? And in all honesty, it's not going to change your treatment. You still have to assess your patient and look at the clinical evaluation of your patient. So we have staging and grading now, which actually takes into that systemic aspect for your patient. So we should be perio charting, and we're going to be treatment planning our patients according to how they're clinically presenting for that. So we should be probing. We should be marking bleeding and separation. We should be marking our furcation areas, mobility, tooth loss, and whether it's localized or if it's generalized. And we need to be looking at our x-rays to know exactly how much bone loss is present. Is there less than 15%? Is there between 15 and 30%? Does it extend beyond 1/3? Right? That gives you the staging and grading of disease. And that's really important. I've learned through consulting that and through coaching, not all offices are, doing recession. If you're not charting recession, you don't know what your clinical attachment loss is, and you really don't understand the disease pathway. Periodontal disease can appear in a number of different ways. It's not just pockets. It's clinical attachment loss. So we can have a gum line that's up here with bone, right? But I can have a gum line right here, and I have a 3 mm pocket, but I have 6 mm of a clinical attachment loss. That's perio. So we need to treat those patients like perio patients. Disease looks different for everybody. So we need to make sure that we're doing a full assessment of our patients so that we know where they're at with their disease process. And then also we need to understand the grading component of it, whether it's fast progressing or slow progressing. Some people are high responders. We need to respond differently to those individuals. With a high responder who has rapid rate of progression, maybe you need to put like a, a periostat in there with a low dose doxycycline where you're slowing their immune system down. That isn't an antibiotic to kill bacteria. You're dampening down that host component that we just talked about a few minutes ago. Super duper important that we're looking at the whole picture for our patient to understand disease pathways. Okay. So make sure, I know staging and grading gets super confusing. It's really, really cool is ChatGPT, you guys. You can put in, this is presenting what's the grade and staging of our patient. We can use tools now to help us with this. I know it's confusing. When this first came out, I was like, I have no idea how to do this. But just make sure you're doing the appropriate charting and assessing your patients properly, and talk about disease in disease language. My biggest pet peeve is I'm doing a deep cleaning or I got a deep cleaning, and patients have no idea they have disease. So we have to stop using deep cleaning and cleaning as language, and we need to say periodontal therapy for periodontal disease. So we need to use disease diagnostics when we're talking to our patients so they understand the disease pathway. Okay, so let's just talk about preventative dentistry with or without our test. So I love this in a workflow. So when we are talking about preventative dentistry, we have an exam and we look for bleeding. And if there's no bleeding, it's pink, thick, stippled, firm, then we move them to a prophy, right? And that's our prevention strategy. And we don't start treating anyone until we get 30% bleeding in our patients. So almost 50% of the mouth has to be bleeding before we start treating gingivitis. And gingivitis is with no bone loss. And this gets a little bit tricky. Sometimes you can have 4 and 5 millimeter pockets, and they're pseudo pockets from inflammation because I don't have bone loss on the x-rays that we have to look at, right? But 30% according to the ADA before we can actually start treating gingivitis, okay? And then we look at bone loss, and that's where we start treating periodontal disease. So without testing, we are looking at observations of improvement based on bleeding points and inflammation. I want to challenge you all tonight to think outside the box of this because I've seen so many tests. I've seen tests on 14-year-old kids who are perio nightmares. But you know what? They don't have bone loss yet. But they're definitely headed towards that if we don't start treating them sooner. Okay. So with testing, we can take our prophy patient and we can add things like laser decontamination or ozone insufflation. Maybe we're going to use desiccation therapy to reduce the biofilm that's causing something that might be brewing that we just don't know because the inflammation's not there yet. So our preventative strategy now becomes, let's capture the bacterial overgrowth before I start even seeing anything going on. Maybe their health history is telling you something different. Or for scaling and root planing or scaling with inflammation, you're actually looking at the bacterial overgrowth and whether you actually have an overgrowth or not, and that's what we need to be treating, and we'll talk about that in a few minutes, or we have something else going on. But you can add adjunctive therapies in and then test again to make sure you subsided the issue that might have taken place rather than just looking at whether it's bleeding. I had a patient just like that. I used a microscope. I did all kinds of different therapies, ozone, laser, and I used GBT, and we did full mouth decontamination SRP treatments 4 weeks in a row. And by the time he came back for his 4 to 6 week eval, he had amoebas and treponema species all over the place in his slide. Pink, stippled, looked better, but his oral microbiome had not been subsided. So he's easily headed back into disease. I just subsided the inflammation locally for now, right? So when we're testing and we're checking in on what's going on, we actually know whether our treatments were effective and whether we're still in treatment phase for our patients. So let's just break down what the test can tell you for a few minutes. So high inflammation with inflammation. This is what we're going to be highlighting today. So I'm not going to spend a whole lot of time in this, but when we have high inflammation scores, we need to make sure that we're putting in treatments that are bringing down that inflammatory issue. And then we need to test more to make sure we brought it down and we're keeping it down because that person is in a cycle of disease and is susceptible to dysbiosis, right? So we can touch in and keep an eye on whether we've got them in remission or not, okay? So then if you're testing more, you're going to find patients who have high gum inflammation scores and they are pink, stippled, and firm. And I think this is probably the best ROI for most offices because you're catching it before they're presenting. So like I said, with that prophy patient, you might want to add in more frequent recare because they're at risk both orally and systemically with the pathology that's present, and add in treatments that might be helpful like laser bacterial reduction, guided biofilm therapy, periopatectrays, different things that we can bring the pathology down. And these patients, even though they're not clinically presenting, you might want to test more often to make sure that you're keeping that risk lower. You're also going to have patients, if you did not catch the course that we did last month, I covered this bucket of patients. low inflammation risk in the test results. So even if you're not using bristle and you've had another test and you're like, this is just not adding up, I don't understand, I have disease going on, and the test is telling me they're not at risk, but I have inflammation, I have bone loss. Well, that determines that they're probably a fast progressor, right? So that's the grading aspect for our patient. And there's a systemic issue going on for that patient. So in the bristle test, look at the gut impact score. Look at the nitric oxide score. That might be an airway issue. There might be a gut dysbiotic problem. There might be some imbalances with the beneficial bacteria. Or that person might have some systemic issues going on that we need to address gut health and nutrition. We need to address systemic inflammation, cortisol, hormones. We might need to address A1C. I have a patient that was like this. She was going to lose her teeth, mobile teeth, and the test came back low pathology. Well, her A1C was 14. Her periodontal disease is driven by her diabetes inflammation. So if we can do SRP to our heart's content on those patients, but unless you get her diabetes under control, she's still going to be in a high progression of disease, right? So the test can give you some really great insights when you start digging into the health history and other components of the test to get some clues. We're not going to cover a lot of decay because we're going to do a lot more on perio today, but same thought process as most of the bacteria that are decay causing are anaerobic bacteria. So think outside the box when you're using your PerioProtect trays. If you're using those, or ozone treatments, or laser treatments, you're reducing biofilm for those patients. So treat them similarly as you would your perio patients in some of those aspects if they're high risk for decay. You're also going to have patients who just don't get decay. They're not susceptible to it, just like they're not susceptible to periodontal disease, but they have high risk. Some of those bacteria can translocate and impact gut health as well. So I highly recommend we reduce the risk factor there as well. And then there's a bucket of patients who they're going to come in with low decay risk and they have decay present. And oftentimes I'm like, this can't be right. I get practitioners, I have decay everywhere. And you're saying they're not risk. Well, bacteria is the only one reason why we might have decay issues. If we have a gut problem and we're not uptaking our vitamins and minerals properly and transporting things, then that leads to decay issues. If we have a poor diet that's full of sugar and we're acid forming, that will cause decay issues. If I'm breathing through my mouth and I'm drying everything out all the time, that's going to cause pH issues and decay problems. Diet plays a huge role. We need our fatty vitamins. If you have not read The Dental Diet or Nourishing Traditions by Sally Fallon, I highly recommend you do that because we need meat products or something in that category of fatty vitamins because those are what carry our sodium, our potassium, our calcium, and put it into place. So if we're missing vitamin A and D and K, we're not transporting properly. And that's once again a gut problem. So we can start referring our patients a lot more effectively if we're testing preventatively. So hopefully that was helpful. Let's dive in a little bit for what you guys came for today. So high risk with periodontal disease and bone loss. So this is someone who is clinically presenting with clinical attachment loss of 4 to 5 millimeters or more of probing. That's including recession, bleeding on probing, possible separation, furcation involvement. Look at your x-rays, figure out your staging and grading. So it's not going to change your treatment protocol for your patient. Your office protocol for SRP is what your office protocol is. If you have been working with me, the platform at Bristle is customizable. I encourage you to set up some templates with high gum inflammation bacteria. with periodontal disease and set up your in-office protocol according to what you're going to recommend home care wise and how they're clinically presenting so that you can just have a template to run and go with. But let's just cover this. So with the scores, you're going to have, and I just brought the scores in so to look at. I'm not going to go into a huge deep dive with this because there's so much information for me to share. I could go on for hours. I don't want to bore you. So beneficial, we have a beneficial bacteria score, a gum inflammation score, a high tooth decay score. We have a high gut impact score in this example. We have a low nitric oxide score, and we have way too high of a diversity. So just looking at that alone is giving you a pretty good indicator that this is a high risk patient. You don't even have to look at the pathology that's there. If you want to spend time with me in a result review through Bristle, I love digging into the bugs. But in a general overview, I pulled the gum inflammation score. In this case, we had, quite a few different bacteria contributing to the gum inflammation score. We're going to really focus on the gum inflammation score for this patient because that's what we're treating. So you don't have to get in the weeds with all the other stuff, but let's just talk about the other stuff in a few minutes. So with the gum inflammation score, we have Peptostreptococcus, we have Campylobacter, we have Fusobacterium, we have Treponema species, which are spirochetes, we have Porphyromonas, P. micra, we have Eubacterium, and Trinella forsythia. These guys play naughty together. Trinella forsythia, excites a more virulent issue with Fusobacterium. So the attributes, the Bristol test will give you attributes. Gram-negative, gram-positive, super cool. For our microscope users, super cool. We have the attribute of how it's living in the mouth. When I first started with Bristol, I was like, can you just add the shapes because then I can know what I'm looking at. But chained rods or cocci are biofilms. So those of you who are using guided biofilm therapy and you're disclosing your patients, that's what's disclosing, biofilm, right? So you can kind of get an assessment. Is it a biofilm or do I have swimming bacteria? So Treponema and Porphyromonas groups are swimming and mobile bacteria. They're just kind of floating around the pocket area. So if they're just floating around the pocket area, your toothbrush and your floss may not be as effective. We need to get a water flosser in to irrigate and clean these guys out. And the really cool thing is you can know how they're living aerobically or anaerobically. So most pathology in the mouth are anaerobes. They don't like oxygen. So when we're using a water flosser, we're putting H2O below the gum line where these guys are hiding. And we're flushing out and we're oxygenating. So that's awesome. We can step that up with H2O2, which is hydrogen peroxide, which is why perioprotectrates are used. So we're pushing hydrogen peroxide below the gum line and we're dealing with anaerobes below the gum line. You can do the same thing in a water flosser sometimes. Or there's ozone water flossers on the market. That's H2O3. So we can use oxygen as a really great tool to help us shift the biome. And then we can add probiotics in. So here you can see the bubble says S. salivarius, L. reuteri. So if we take that bubble, we can then make a really key decision on what oral probiotic I can add in. And oral probiotics are like companion plants in the garden. They help us to counteract and shift the biome. We're putting good bacteria in that act as bacteriocins towards other pathogens, and they help to correct those pathogens. So another really cool way that's not super antimicrobial and catering to bring this average beneficial score up, right? And still counteract some of the pathology we're dealing with. The gut impact, we talked about the gut impact score, right? So the gut impact, if we have a high gut impact, maybe there's a leaky gut problem too, contributing to our disease. So we're looking at the oral bacteria that can translocate and exacerbate inflammation in the gut, which is going to infester those cytokines to bring them over here, right? So we want to reduce that gut impact score as well. And then the nitric oxide score should be high and in green, just like the beneficial score. So that nitric oxide score could be they've been overusing antimicrobial rinses, or they're a mouth breather. So if we have a low nitric oxide and we're having a hard time pushing that nitric oxide score, I highly recommend doing a sleep study, maybe referring to myofunctional therapy. Make sure that your tongue scraping, they niche out on the tongue. Sometimes we'll get a tongue coating nature, but we want the nitric oxide score high because if we don't have nitric oxide, we don't have good blood flow. And we're not going to have good cells coming to help us with the infection that's taking place. And the diversity, you should be bringing the diversity down through your treatments of biofilm disruption. So something that you could think about for treatment considerations for this patient. LANAP, if depending on if you refer or if you have an office capable of doing LANAP surgery, this patient needs a pretty significant biofilm disruption. If it's someone who you haven't treated lately, then you should put them back in retreatment. They're not stable. So, you could do laser bacterial reduction, desiccation therapy, ozone treatments, whether that's insufflation or tray treatment, gingival irrigation. We talked about periostat. That's a low dose doxycycline. If we have a patient who is, a more high progressor or a high responder, this could be a good tool to help dampen down that immune system. It's not antimicrobial, you're dealing with that host component. Of course, air polishing is, biofilm based, so I think that's awesome. And then think about OHI, think about nutritional counseling. Those are some really great things you could start leveling up your care to really think about what you're doing for your patients. So let's just talk about home care for just a moment. Of course, electric toothbrushes show a lot better clinical efficacy when it comes to plaque biofilm removal. Antimicrobial toothpaste can be used short term. I personally love biocidin for treatment. We can use ozone-based products. There's ozone oils, there's ozone water flossers, there's ozone and essential oil based. Omega-3 has one, I think is the name of it. Puro 3 is one that I use quite a bit that have ozone incorporated. Make sure your patients are doing proximal care. So floss, demo floss. People don't know how to floss properly. They get hounded about not flossing. Maybe they are flossing. They just haven't ever been taught how to adapt their floss. Super important to spend time doing that. Proxy brushes are more effective. Maybe an end tuft brush is way better at, getting along the gum line for our patients. Water floss, I am a full believer that we need to floss and water floss. We're dealing with different niches of bacteria. Floss helps with biofilm-based bacteria. A water flosser is more on those swimming guys. So the treponemas, the porphyromonas groups. Think about oral probiotics, short-term antimicrobial rinses. I say that I use antimicrobial rinses all the time, but it's short-term. I do 2 to 4 weeks depending on what I'm using. Because if we are tilling the garden every single day, we wouldn't take amoxicillin every day because I'm going to have a gut problem. Same thing in the mouth. If we are overusing antimicrobials, we're wiping out everything and then we're not ever growing the good stuff. So antimicrobials should be used as a therapy. And then nitrate supplement, I always say support pH. And really, you have to support dry mouth. So there's great products on the market now for dry mouth. Some are, xylitol based. Some actually have enzymes in it that mimic and assist the saliva in general. So amylase, Periovance has amylase. There's a couple of different products like Salvia that has a number of different types of enzymes in it. And then Oral 7 is another one that has enzymes that act more like saliva to support the oral environment. Those are really key importance in keeping homeostasis in the mouth. Diet plays a huge role. So the more carbohydrates and processed foods, we're going to have dysbiosis. high fiber, high protein, high nitrate rich foods. Know that some people have an oxalate issue. Oxalates are, beets and certain vegetables have an oxalate in it, and some people can't process that. So assess that. If they do, then sometimes they put them on a supplement that doesn't have that in there. And then consider supplementation, vitamin D, K2, A, vitamin C. Vitamin deficiencies, it will show up as inflammation in the mouth. B, CoQ10, vitamin E can help. Nitrates, so, if you do a nitrate supplement. And then consider trace minerals in your water. Some people drink reverse osmosis water. Their water is void. It's not doing their job. So you have to add in some trace minerals. Those trace minerals will help with remineralization, both of the bone and of the teeth. And then consider collaboration to help treat our patients on that perspective. So let's dive a little bit into nutrition a little bit. Why do I make those recommendations for supplementations? Well, vitamin A can show up in the mouth as dry mouth, gingival inflammation, and impaired healing. Vitamin C deficiency can be bleeding gums, delayed wound healing, scurvy. We all were taught about vitamin C and scurvy, but most patients are C deficient. Vitamin D, enamel hypoplasia issues, increased caries risk, increased periodontitis. Vitamin E, inflamed gums, oxidative damage to the tissues. Vitamin K, excessive bleeding. Vitamin K2 carries calcium and locks it into the system. So we need to make sure we have those. Vitamin B, there's a lot of people with vitamin B issues, especially if they have MTHFR. So that can show up in the mouth as glossitis, burning mouth syndrome, mucosal atrophy. And then we have the minerals present, which is why those trace minerals can be super helpful to add as well. So, deficiencies with, gut issues lead to vitamin issues, lead to mouth issues. So thinking outside the box with that. So level up your home care, make sure that you're demoing how to get the toothbrush in the right place, how to floss and use the proxy brushes. Make sure they're tongue scraping. Make sure they're using a water flosser. I think everybody should use a water flosser. Think about oral microbiome supportive approaches. So short-term antimicrobials, whether that's oxygen-based or, closest SmartMouth. Bristle recommends SmartMouth CPC have really good efficacy against, some things, but make sure it's short term. It will absolutely blow out your beneficial bacteria long term. Think about things like arginine, nitrate, inulin, and probiotics. Hydroxyapatite can be helpful without being antimicrobial. Pre and probiotics can support our patients in that perspective. And then integrate good treatments for your patients. So thinking just beyond hand scraping or even honestly cavitation with a piezo or a cavitron, start leveling up and integrating more biofilm based types of treatments to help desiccate. Maybe desiccation therapy is pretty awesome. We can talk about those things. So I love phase contrast microscopy for checking in during treatments. So I think that's a difference than salivary testing because we can look at the biofilm. So ultrasonic instrumentation, I'm hoping that all hygienists are using this every single time, every single patient. We're talking about biofilm disruption. I took my daughter to someone a couple months ago and she had braces and the hygienist didn't use a cavitron. I was like, well, she's got braces. She's used to a cavitron. And she's like, yeah, that's good. Scrape, 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 polish. I was like, not coming back. So we have to think about biofilm disruption. We should at minimally be using cavitation processes. I think most of you are. Air polishing, EMS has had a system out forever. Now there are other units that there are available. So Hugh Freedy has one. So some are using erythritol based, and erythritol is highly effective against biofilm, and some are glycine based. The new Hugh Freedy one is glycine based. These are great. It's really kind to the tooth and it's really kind to your patients. And it really does a fantastic job at supra and subgingival biofilm disruption pathways. So it's expensive. It's well worth the investment, in my opinion, as someone who has used it Disclose your patients, people, if you have it. Guided biofilm therapy means you're disclosing so you can see. You can't always see the biofilm. Even if you're not using an air polisher, I challenge you all to start at least using plaque disclosing solution, whether it's two-tone. I personally love Triplaque by, sorry, my brain just like fell out for a second. Triplaque by GC, I do believe is the company. But what that one does is you paint it on. It's kind of a thick gel. I used to water it down a little bit because it was a huge mess. Put an Optigate in so the lips are out of the way, and then it paints on beautifully. Then you rinse it off. And it's purple, it's bright pink, or it's blue. So the pink is new plaque. The purple thick stuff is stuff that they've left for a couple of days. And the bright blue is below 4.5 on the pH scale. So it's destroying the enamel. So it tells you a lot in that. And it's a great teaching tool. So off with that. But anyways, laser treatments for biofilm disruption. Some bacteria embed into the tissue. PG is one of those. If you see PG in the test, please consider one of the two options. Laser treatments to penetrate into the tissue to capture that Porphyromonas gingivalis. If you don't have laser, because not all of us have the ability to practice with lasers yet in today's hygiene craziness, you could use desiccation therapy. I think this is a really, really great option. So desiccation is the use of a gel or a liquid, and it's a sulfonated gel that you paint on. You usually do about a second at a time. You paint it on along the gum line, and it desiccates the tissue. So the tissue will look a little bit paler. And that's because we dried out the tissue, which means we've penetrated the tissue where that PG is sitting, which is awesome. And it desiccates the biofilm. So it's killed the biofilm completely. It also desiccates tartar and calculus. So it's easier to remove the calculus deposits, which is awesome for you guys. So win-win there. And Anne Guion is running a course right now on perio-DT. It's awesome. If you have not taken that course on the desiccation, please hop there and learn from her. It's amazing. The study that she shares, I need to get my hands on because it shows if you desiccate at the start, rinse, and do your treatment, desiccate at the end, and then use your Cavitron again because it might be some tartar left behind. You're killing the rest of the biofilm that might have been present. The study showed 1 year of efficacy for those red and orange complex bacteria. That's amazing. So we need to think about biofilm disruption pathways when we're treating high pathology in the mouth. And then ozone therapy is awesome. If you're in a biologic practice, you probably already know this, but ozone is O3. It is awesome. O3 kills anaerobes, which is amazing. It helps with mitochondria. It helps with red blood cells carrying oxygen to the rest of the body. It's super healing. It's wonderful. It was life-changing when I went into hygiene, into a biologic practice. I saw great results with it. So you can use it as a gas in the office with insufflation. You have to use a suction with it so they're not breathing it in. You can use it as products for your home care at home. If you don't have ozone in your office, there's a ViaJet ozone machine now that is a water flosser that incorporates ozone. There's a handheld one on the market too that you can utilize. And then there's ozone gels and other things that we can incorporate into our patients' home care routines if you don't have access to ozone in your office. I hope this is super helpful. And then so we did leveling up and integration. So now let's talk about assistance. So when we have low nitric oxide and we have a high gut impact and you're having a hard time moving these, I recommend a sleep study. I recommend checking for snoring, looking at Mellon-Patty score. And some of you may not know what Mellon-Patty is. Gotta look at the back of the throat. Can I see the tonsils? Can I see the uvula? If it's I can see the whole thing, it's 1. If I can't, the more I can't, it's 4. And if it's like this, they're not breathing. So learn how to do a Mellon-Patty score. At minimum, look for ridges on the tongue. Look for, clenching and grinding. Those are just some key. Look for a tongue tie. If your patient gags when you take x-rays, their airway, send them to a myofunctional therapist. Get them into a sleep study. Make sure they're breathing because that's going to excite cytokines and cortisol. Okay. So super important that we do those types of referrals. That nitric oxide score can give you some real cool hints into that. And then the gut impact. If we have a gut problem and you have that gut impact score, ask, do they have IBS, Crohn's, SIBO, SIFO? How often do they go to the bathroom? Are they going to the bathroom? Like constipation could be a really big problem. I know we're used to talking about the mouth and not really the other end, but those things make a difference for our patients' health. So evaluate that. It could be mineral and vitamin deficiency issues. So working with a functional doctor or nutritionist can help us gain a better positive outcome for our patients when we're assisting them through effective referrals. And I invite not just refer, but try to collaborate and communicate with those individuals. It's important for the doctors to start learning how the oral environment impacts systemic health, and we need to start forming better relationships with our counterparts in the field. Okay, take a deep breath. I know that was a lot of information. We're going to take a minute and let you go grab a glass of water. I know that was just a ton of stuff. We're going to go into a case study and then we'll wrap up. I know this has been quite a bit of information so far. If you scan this, the 2 winners will get a 3-pack of the Bristle probiotics. So we will just collect a little bit of information and get that sent out. And I'll give you just a few minutes to kind of take a breather. I know that was a lot of info. I love teaching, guys.
I would also say we just put the link of this QR code in the chat. If you have any questions you want to send over, feel free to send those in the chat too, and we can start collecting those for whenever you want to do questions, Heather.
Yeah. So at the end, if everybody's open to it, I did have a list of questions. I'm hoping I answered most of them, but feel free at the end to, come on mute and feel free to ask questions, even, outside the chat. I'll try to answer whatever comes into the chat, but I'm fine with conversation too in that perspective. So I'm just gonna assess. I'm trying to see if everybody's back in. So in lieu of time, I'm going to go ahead and start the case presentation. So this was a case that was shared. So the treatment that's in there was what we talked about doing based on the findings. It was super nice of the office to let me share some of this data. But health history, we have diabetes, high blood pressure. We have extensive bleeding with probing throughout the mouth, and generalized 4 millimeter pockets with 1 local 5 millimeter pocket. History of decay with crowns and fillings. So in the chat, what would you treatment plan for this if you don't have a test? Just out of curiosity. I know I don't have x-rays. They did not share the x-rays, so it's hard to make an assessment in there, but I have to find the chat. Let's see.
No responses yet.
No, yeah.
People might be typing.
Oh, yeah. Okay. Well, I'm going to move on because I can't find the chat. But so let's just talk about diabetes and periodontal disease for just a moment. So individuals with diabetes have a 24% increased risk for developing periodontal disease. And people with periodontal disease has a 26% higher risk of developing diabetes. So that's a big red flag there. So, and what happens in diabetes, we have a hyperglycemia situation and we have a rise in those interleukins in the crevicular fluid, which worsens the periodontal status. And then periodontitis excites CRP and tumor necrosis factor alpha, which then contributes to more insulin resistance and impaired glucose control. So keep that in mind when you start looking at your patients and start diving into their health history. I know sometimes we get so busy, but start thinking about the health history and how that's impacting, their disease pathways. So with that, let's just talk a little bit about sugar for a second, because diabetic patients have a love-hate relationship with sugar. I have a sister-in-law who's type 1, and she has to keep candy next to her because if she has low, dips at nighttime, she's got to pile drive some sugar in to get her levels high. Well, if we have to do that, then we're going to inflate the inflammatory response. So even with those diabetic patients, we have a lot of flux with sugar issues. With that, sugar then can also be a problem for our patients with inflammation. So think about that perspective too. So what makes this a good candidate? I blew it. Okay, so diabetes, high blood pressure, and the pocketing that's present, especially with diabetes, it makes this patient a really good candidate to test. So if you're not using Bristle, I did bring in on the homepage, they will bring most of what you're looking at in any of the other tests right at the front part. So the red complex, orange complex, and a few of the bacteria that are capable of causing decay issues are on the homepage there. And it's really cool because it gives you the systemic health associations tied to the bacteria that are present, the level of, how that plays as far as risk factor is listed, and then the percentile is there as well. If you're in, the 79th percentile, that means you made it to the 79th percentile of all the tests for that type of bacteria. So the percentile is giving you an idea of how you are, in the risk category. So diving into this person's test results, I did bring the health history forward so we could remind, diabetes, high blood pressure, extensive bleeding. We have mostly 4 millimeters and 1 5 millimeter pocket. We have low beneficial bacteria. We are high or needs improvement in the gum inflammation. She is at risk for tooth decay. Just looking at the base oral health insights for there. So she's at risk for decay, and she's had decay in the past, so we want to bring that down. But when it comes to perio, she's got AA in there, guys. So we really have to think about AA. I don't see AA very often. I'm so versed in the oral microbiome, and I still can't say that damn bacteria. So we're gonna just call it AA. So, but Streptococcus, Campylobacter, Eubacterium, Fusobacterium, and Treponema and Porphyromonas is in there. So a pretty high risk. We know AA can excite quite a bit of issues. So we want to make sure that we're subsiding the biofilm for that patient, especially with the diabetes issues. Her tooth decay score was Prevotella denticola. Strep mutans is in there. Candida is in there. Candida is in every single test. It's a commensal. It's under 20%. Sometimes I wonder what the threshold is where that impacts the gut health, but I usually watch that and see how it goes. But pay attention to Prevotella denticola in the test for individuals. I see that more frequently than strep mutans to cause decay issues. So this patient is in dysbiosis. Very low beneficial, so we want to bring those up. I would want to support, that and make sure that she has a good immune system in play. And I want to reduce the pathology that could lead her to disease. So let's just talk about AA. It's a biofilm. It forms a biofilm. So it's capable of forming resilient biofilms. So it's going to help protect those bacteria. It is very virulent in a lot of aspects, and it will excite lipopolysaccharides, which LPS is really problematic for a lot of patients and excites a lot of inflammation in our patients. I work with a functional medicine doctor, and she talks about LPS all the time. So super important that we reduce, any LPS issues in our patients. It's aggressive periodontitis and usually chronic in nature. I've seen it in other patients who don't, but when we have it there, I try to take it pretty seriously, especially if we have other bacteria playing in the sandbox with him. So we want to make sure that we're doing mechanical disruption of the biofilm with SRP. And then you would consider, antimicrobials, possibly laser bacterial treatment, ozone, desiccation therapy are some things that I would consider, especially dealing with this and the biofilm that she had going on. And she has some of the key stone pathogens that are present. And what happens, plaque is usually not very organized in fashion. And as it gets older and more colonized, we get some of these key pathogens that come in, and the biome becomes a lot more controlled and structured, and then it leads to a dysbiotic stage when we start getting some of these key pathogens in play, and that can lead to dysregulation of the immune system. So when we have some of those red complex bacteria playing a role, we know we have a biofilm that is in dysbiosis, and it's really well organized, and they feed each other. They work with each other really in a really cool facet that causes dysbiosis and destruction of tissue. Some of these bacteria will eat or feed on heme or purulence and inflammation. So as they come in and cause that inflammatory response, their food becomes that inflammation. So we want to make sure that we reduce the inflammation. Sometimes that's by reducing the host component for our patients in that aspect, for making sure that we're subsiding disease. So the analyzing the health and wellness insights. So she had halitosis that was opportunistic, which is sort of a good call out. I do look at the halitosis score because it'll say tongue coater, it'll say gum liner, or opportunistic. The opportunistic is a red flag for me. I start looking at that, and the gut impact will show with the opportunistic as well. So she has Klebsiella in her oral microbiome as well. I am speaking at the IOMT, and I'm talking about oral dysbiosis by overgrowth of some of these species, and Klebsiella is one of those that I'll be covering for that. But Klebsiella pneumoniae and Klebsiella species is driving that gut impact score along with AA, Campylobacter, and Fusobacterium. So we have 3 pretty big players, 4 or 5 big players that can impact gut health for our patients as well. Her nitric oxide score looks decent. Her diversity is a little bit on the lower side. 1 is a red flag for me. So we really need to understand the inflammatory issue with the inflammatory bowel thing and how that plays a role in disease progression. Because when we have a dysbiotic situation, so that Klebsiella was at 46% relative abundance. So in the back of the test, I'll look at the raw results and look where Klebsiella was. So this is an extreme diversity issue in some components. So she's got perio-pathogens in there that can drive disease pathways. And then she has an extreme overgrowth of Klebsiella pneumoniae at 46% of her oral microbiome. And Klebsiella is pretty problematic in itself. So it will drive that lower diversity score, which will drive the low beneficial score always when I have an overgrowth in this situation. Super important to look at these pathogens even beyond sometimes the red complex. So let's learn a little bit about Klebsiella. It's generally something we pick up from our environment. It's a facultative bacteria. It's opportunistic in nature. It really only shows in about 6% of our cases that we see at bristle. So it can be picked up from your environment. So I usually say, if this person had any type of devices like a guard, or if they had any type of partial, or their toothbrushes, I'm putting those in an ultrasonic cleaner, and I'm making sure that we're not picking up stuff from our environment. Make sure they're washing their hands. But it's a number 1 infection in hospitals, and it's due to poor infection control. And it's really problematic for our patients who are immune compromised, especially with alcoholics and diabetics. So we want to make sure we treat this because she's a diabetic. So a really cool kind of breakdown for those of you who are working with a microscope. So Klebsiella pneumonia. There are some other ones that I'll be covering in a CE course at IOMT, which is super exciting. It's my first live. So the enter KCI groupings are who are doing these opportunistic situations. It's biofilm based. It'll disclose. So we need to make sure we're doing good biofilm disruption, but it's also passed by poor infection control. So make sure that you're using good infection control processes in your room so that we don't have it aerosoled and on our surfaces for somebody else to pick up. And these pathogens tend to be antibiotic resistant. So you have to be careful with those. And they trigger a lot of inflammation and gut permeability issues. So the enter KCI groups, comorbidities tend to be kidney disease.
Whoa.
And they cause some pretty significant dysbiosis. It's been a deep dive for me that's been super fun. But anyone who's using anything with extra devices, and the elderly tend to be more problematic for that. So soak those things that you are putting in your mouth, your Invisalign trays, your partials, any of those. Encourage people to use an ultrasonic cleaner because they do make their way down to the gut. And this is a gut zoomer test. And enter KCI is at the top of this, and it does cause intestinal permeability issues. It's really found like 6% of our tests only have it, and it's rarely in any type of healthy oral microbiome. So it's really an indicator of disease pathways for our patients. It can cause some halitosis issues in some individuals. Once again, it excites inflammation and LPS. It's cytokine signaling and increases intestinal permeability issues. So, that would be problematic for this diabetic patient, which could lead to that vitamin deficiency that we kind of talked about earlier. So, we want to make sure that we're getting that gut dysbiosis issue under control if she has it. Most likely she does because she's got diabetes. And Klebsiella acts a little bit differently too. When it gets into the mouth and in the bloodstream, it can cause autoimmune issues through some pathways. So certain bacteria, when we swallow them, they can excite a molecular mimicry situation, or they amplify autoimmunity and cytokines. And those cytokines will then cause an autoantigen overproduction. Diabetes is, a metabolic pathway, and it's where the pancreas stops working, its autoimmune component. So definitely can exacerbate that for her. So we want to use strategies. In my experience with these bacteria, I've used ozone. I have found that green tea and herbal rinses can be helpful. Natural things. Tea tree is helpful for that. I've used biocidin. I've used products like Risewell that has tea tree and cinnamon. I've also used Guru Nanda Ceylon cinnamon that has neem for some of these pathogens as well, but for use there. So super helpful to make sure that we're disrupting biofilm. And xylitol. So the other really cool thing, we have a case study in Bristol on Serratia marsicans, same exact grouping of bacteria, and xylitol inhibits the ability of that to replicate. So xylitol has been used successfully several times. That's one of the top ones for Serratia that I use. So I use the same strategy for that. So I usually have people using half a teaspoon of xylitol in warm water on a real simple note to help too, because it'll stop the mobility and the quorum sensing of these enter KCI groups. So let's talk about leveling up care for this patient. So with diabetes, high blood pressure, and this, I did talk to that office. She hadn't had an actual SRP at that point, but we kind of talked about the possibility that I think it might be to the point where that would be a good idea. So SRP is a great asset to make sure we get her under control because she's diabetic and showing some issues. Desiccation therapy was discussed, laser bacterial reduction. So really leveling up care on that dysbiotic biofilm, and even Periostat might be a good option for her just because of the diabetes in that component. And then test and retest to verify. So this is a fairly new case that was that came to me. So this is what we treatment plans. She's going to do scaling and root planing. We're going to do that with laser assistance. We're going to do a 4 to 6 week eval and then retest to see how we're doing and continue treatment until we get her into homeostasis. For home care, we made the decision to, they're using gum detoxify toothpaste, making sure that she's flossing at least twice a day, using either the water flosser with hydrogen peroxide or a Viajet ozone water flosser, tongue scraping. They opted for tooth and gum tonic, which is another really great antimicrobial that has all of those, polyphenols that I talked about that could be assisting with that as well. And then Supermouth is a high xylitol based rinse with vitamin D and K2. They have hydroxyapatite, it's 8.5 on the pH scale, and it can come with or without fluoride. So it's great for, whichever boat you sit on. So if we want a regular rinse that's going to be inulin and feeding and not antimicrobial and extra xylitol for that Klebsiella, then that's a good rinse. Or on a real simple, easy note, taking a half a teaspoon of xylitol and warm water could be a great way as well. We started with BioGaia because the enterococci groups are susceptible to Lactobacillus rudii, and then followed by bristle because it's more broad spectrum to get those beneficial bacteria up, and then also treat some of the other ones that are sensitive to other types of probiotics was what was discussed for that patient. So we really leveled up the care from going from a prophy with a little bit of bleeding and just a 5 to let's do our periotherapy. Let's do some extra stuff to really make sure we're catering to what we found in the oral microbiome. Probiotics, super helpful. They're like companion plants. Beyond that, she had low nitric oxide. So we want to make sure we're supporting that with some sort of supplementation, making sure she's not mouth breathing, support pH with gum and xylitol, using an ultrasonic cleaner for anything that she's using in the mouth, including your electric toothbrush and your water floss tips, anything we're using in the mouth, because that Klebsiella is picked up from the environment. I love Oral 7 gel with the different types of enzymes to make sure that we're supporting saliva health in that component. So that was how we kind of really leveled up the home care. And then we did discuss making sure that we talked about making sure her A1C was well controlled, possibly working with a functional nutritionist to assist, especially with some of the Klebsiella species that were present, knowing that she has diabetes and trying to capture a little bit better control over the systemic disease pathways that she had. And as a rule, I think it's always good to rule out any airway issues. So not a bad idea to consider doing that. So functional nutritionists can help us support a balanced oral microbiome by recommending proper food. It can help promote nitric oxide reduction. It can help with systemic inflammation issues, and it will assure that they're properly hydrated and have minerals that we need to help support our patients' bone and tooth health and salivary health. So when we pull in and really work with our community, we can help as a whole body rather than just scaling and root planing. So with salivary testing, it becomes really objective, and we're basically looking at whether we've correct things, by bleeding points or inflammation or progression of disease or decay without, that is. When we're using salivary testing, we're being a lot more science-based and looking at the dysbiotic situations and whether we've actually corrected and brought them into homeostasis, and we're treating the patient as a whole through using saliva as a protocol. And that wraps it up. So thank you, you guys, so much for joining. I greatly appreciate you spending the evening with me. Super excited. If you haven't done a result review, schedule one. And thank you so much.
Excellent. Thanks so much, everyone. And thank you so much, Heather.
All
Talk
right.
to you all soon.